I have the same concern about the 17p deleted. If by any chance patients end up being on venetoclax because of intolerability or concerns for tolerability of BTK inhibitor, I tend to continue the treatment beyond the 1 year mark, because I think the data that they showed at ASH is that they drop off pretty interestingly after the venetoclax is completed. Now, of course, for the time-limited therapy, there's the question of depth of response. If we look at the CLL14 data of discontinuation of treatment, it seems that the patients who had MRD detectable disease tend to relapse much more than the patients who had undetectable MRD at the completion of therapy. So is this something that you're doing generally for patients who are planning on stopping treatment? I've been trying to do a peripheral blood MRD in the patients who are venetoclax at the end of the 1 year mark to see if I would continue the treatment or not at that point. And a second question would be the 11q deleted patients. As we see with the BTK inhibitors, these patients had tremendous responses to that. And in fact, if you look at there's no head-to-head comparison, but if you look at the curves, it seems that the patients who have 11q deletion and take a BTK inhibitor tend to do even better than patients who don't have an 11q deletion in the trials. So what are your thoughts about that?
So regarding the MRD issue, I think it's absolutely critical in terms of evaluating response on venetoclax and obinutuzumab. What we don't know is whether continuing really improves their outcome, right? So I think what we actually need for that is serial MRD data showing whether patients continue to improve. So if a patient's continuing to improve as they get to their 1 year mark, I'd be definitely inclined to continue and see if they continue to improve and get to undetectable, right? But if patients sort of stabilize and are not improving, the question is, does continuing really make a difference? And I think we see this a little bit in Murano in the relapsed venetoclax rituximab study, where many of the patients who had high MRD, who relapsed very quickly after stopping at 2 years, their MRD was already rising at the end of the time of venetoclax. And so there's still a lot we need to learn about that. But in general, I certainly do favor an MRD guided strategy. The 1 year was just chosen basically as a convenient duration of therapy. And I think there are probably patients who need longer than that to get to undetectable. And I agree with you, though, that even independent of MRD, 17 patients on venetoclax I worry about, and I would probably be inclined to continue them even in a frontline setting. In a relapse setting, I definitely continue them, and especially if they've had prior BTK and progressed. Those are patients who I don't think you're likely to want to stop. Most of them don't get to undetectable MRD. Most of them don't get to CR. The CR rate was only 9% in the study of venetoclax post-BTK. So they need to continue. Now, the 11q, that's an interesting question. I have to say that I'm not sure I completely believe the data that they do better on ibrutinib. I do definitely believe that they don't do worse. But I feel like the curves may be converging as we get to longer times. It's interesting. I wish we had data, and I'm not aware of any, breaking out the outcomes of 11q patients treated with venetoclax. I feel that venetoclax has some similarities to chemoimmunotherapy. It achieves deep responses rapidly, and it's time limited, and then we stop. And so hence we see 17p patients, they do better initially, they get a deeper response, but then they're relapsing. So I wonder if we're going to see the same thing with 11q patients that we saw with FCR. They get a better response than 17p initially, but they relapse earlier still. And I wonder if that will happen with venetoclax obinutuzumab, which is another factor to consider, in addition to the fact that maybe sometimes they do better on ibrutinib. I haven't seen a good biological rationale for why they would do better than other patients.
Yeah, I mean,
maybe they're more unmutated. It may be the case that they have just higher levels of CR signaling chronic.
It's a possibility.